Hello and welcome to the daily wrap-up of the second day of the digital experience, the ESC Congress 2020 here from Amsterdam. My name is Gerhard Hindricks and I have the privilege to host this daily wrap-up today together with two key opinion leaders from the field of cardiovascular medicine. And it's my pleasure to welcome Sonia Petronio from Pisa, Italy. Sonia, thanks for joining us. And Stefan Windecker from Bern in Switzerland. We've seen marvelous clinical trial studies and interesting news from basic science today, again here at the ESC Congress in Amsterdam as a virtual digital event. And we would like to summarize for you the hottest and most interesting news from today's scientific program. And I would like to start off with introducing the popular Tavi trial. So we move to the field of percutaneous valve implantation. Sonia, what was the popular Tavi trial about?
Well, popular Tavi presented was, let's say, only one cohort of the two cohorts of the trial, looking the difference by treating with the single antiplatelet therapy against double antiplatelet therapy in all patients that didn't need anticoagulation for other reasons.
So patients without anticoagulation, and the comparison was aspirin versus aspirin plus clopidogrel.
Yeah.
Was it a randomized trial?
It was a randomized trial, 1-to-1, that included around more than 600 patients for that single cohort. Mm-hmm. And it was very interesting. It lasted for 1 year follow-up, and it gave positive for superiority in the first endpoint, that was all bleedings, for aspirin as single therapy, and for not procedural bleeding. That were the main two primary endpoints. And then it showed a positive effect of the single therapy for a composite endpoint, looking at death, at bleedings, and at stroke for bleedings, and instead showed only a non-inferiority result for aspirins against the double for what concerns the ischemic part of the composite endpoints. That means for ischemic stroke and myocardial infarction.
Yeah. So, Stefan, what is your interpretation of that result? Is it a clear advantage for aspirin monotherapy for those patients as compared to aspirin plus clopidogrel?
I think in the patient population study, it indicates that less is more, so that an aspirin-only strategy is superior in terms of bleeding. I think there are two caveats to keep in mind. First of all, the exclusion criteria, that is patient with a recent stent implantation or another indication for dual antiplatelet therapy, they were not included into the trial. And also randomization was prior to transcatheter aortic valve implantation. So part of the bleeding was driven by excess site and procedural bleeding.
Thank you, Stefan. We move on to the field of ischemic heart disease. The drug trimetazidine has been discussed for many, many years, and now we have a conclusive trial on the value of that drug, the AT-PCI. What type of trial was this, Stefan?
So this was a large-scale, placebo-controlled trial in about 6,000 patients that were randomly assigned to either trimetazidine or placebo in patients with chronic coronary syndrome or recent non-ST elevation ACS, with all patients having angina prior to treatment with PCI, and PCI had to be performed within 30 days of the randomization.
Mm-hmm. What was the major outcome of that trial?
So the primary endpoint of the trial in terms of efficacy was a composite of cardiac death, cardiac events leading to hospitalization and recurrence or persistence of angina. And in that trial, that actually had to be extended. It was an event-driven trial for 1 year. During long-term follow-up, there was absolutely no difference as it relates to the primary endpoint or any individual components of the primary endpoint.
So that is, Sonia, the strength of prospective randomized trials, because the drug has been discussed for so many years, and now we have at least
we have
a clear call.
idea that it is not worth using it. Yes, at least in these sort of kind of patients.
Let's move on to the field of SGLT2 inhibitors. We had great clinical trials presented yesterday on empagliflozin, and today we've heard the latest trials on DAPA in chronic kidney disease. What type of trial was that?
Well, this was a very important trial, a trial that sorted out more than 2,500 patients and was meant to compare the drug against optimal medical therapy, including ACE inhibitors and the other angiotensin receptors blockers. And it was, let's say, 1-to-1 randomized trial, and the importance of this trial was looking mainly to the slower down of the failure of kidney function, and of course of the amount of cardiovascular mortality and kidney mortality or extreme kidney failure.
So that was the primary outcome of the trial?
Yes, that was a more composite. And then the secondary were divided in all mortality and the single part of the composite endpoint. And the extreme importance of the trial is that was stopped before the ending of the enrollment, because the independent committee saw that the advantage of using this drug was always significant for all the endpoints and for all the subgroups of the analysis. So I think it's a very important message. So the drug, that was already been proven to be effective in heart failure, demonstrate a good advantage in influencing kidney failure.
Is that, Stefan, in your perception, in line with the previous trials that have been reported on SGLT2 inhibitors? Is it a big surprise for you?
I think it's an important additional piece of evidence because if we look back, there were concerns about glucose-lowering therapy. Yeah. So the first trials that studied dapagliflozin in diabetic patients were very positive. This was then followed by the DAPA-HF trial now in diabetic and non-diabetic patients, where actually the benefit was very pronounced, both in terms of heart failure hospitalization and cardiac mortality. And now we have an extension of what, again, is applicable for diabetic and non-diabetic patients in patients with renal failure. And to have a drug that improves important clinical outcomes in patients at a high risk for cardiac adverse events is certainly a major progress.
Yeah, and it will have an impact on daily practice. I'm sure about that, and it gives us security and safety in treatment in that patient population. Looking to the guidelines, we have seen the NSTEMI guidelines presented today, Stefan. You have been for 4 years the chairman of the CPG, guiding the whole process. NSTEMI guidelines, what were the key elements, the key messages from the 2020 NSTEMI guidelines?
So first of all, I want to applaud Holger Thiele and Jean-Philippe Collet, the both task force chairpersons and the entire task force, for producing yet another major guideline 5 years after the last edition had been presented, for a topic that is very important in clinical practice because of its high cardiovascular cardiovascular morbidity. Now, I think important highlights are the 0-1 hour high-sensitivity troponin algorithm that really accelerates the diagnosis or the rule-out of patients with non-ST elevation myocardial infarction with a high diagnostic precision. Other important aspects in that guideline that are highlighted are the antithrombotic treatment. And in this guideline, it is clearly stated that routine pre-treatment with a P2Y12 inhibitor is not recommended. It is only reserved for those patients where we don't consider an invasive management. The guideline also provides a very nuanced recommendation as it relates to the intensity and the duration of dual antiplatelet therapy, and really individualizes it based on the ischemic and the bleeding risk. And in that context, one important recommendation relates to antithrombotic treatment in patients with atrial fibrillation that require oral anticoagulation. There, the clear recommendation is to favor non-vitamin K oral anticoagulants over vitamin K oral anticoagulants, and to favor dual antithrombotic therapy after hospital discharge over a triple antithrombotic therapy.
And I think the NSTEMI guidelines also put a call on the definition of quality indicators, better quality management in that field.
So this is very important for future outcome, because the guideline needs to be implemented in clinical practice. We need data to measure this in individual institutions, and therefore this is a very welcome asset.
Absolutely. The measurement of quality indicators is the key in order to improve the quality of care. You can't improve without measurement. That's a strong call from the NSTEMI guidelines. Thank you, Stefan. And we move on to another exciting trial that has been performed in the field of heart failure with preserved ejection fraction. I mean, we have seen over the last years so many disappointments in the field of treatment of heart failure with preserved ejection fraction. And now the Parallax HF trial has been presented. Sonja, what was the key aim of that trial, and how was the trial performed?
Well, the trial was thought, let's say, following what already the Paragon did last year. And it was looking to the effect of sacubitril/valsartan against the individual medical therapy of a patient with heart failure but preserved ejection fraction. And it was looking to the increase of NT-BNP, pro-BNP, and the quality as measured by 6 minutes working test, or as second endpoints, there was the questionnaire of the Kansas City questionnaire and the NEAR class. And it was interesting to see that the result gave a positive result for what concerns the decrease of BNP, but didn't find a difference in 6 minutes working test. And also the secondary endpoint had a particular, let's say, transient effect at 4 weeks, but after that, the two kind of therapy didn't find a significant difference. So in one positive aspect was that they were able to find a decrease in hospitalization. And that was, let's say, one positive. But it didn't give such a main difference between the individual therapy of the patient and adding this new drug.
Yeah, so it's a small step forward, but there's still a lot to do for patients with heart failure and preserved ejection fraction. Will that trial have an impact on practice, Stefan?
I think it gives a glimpse of what still needs to be done. And I think we need to recognize that this was a short-term treatment out to 6 months. And we see mechanistic benefits, but really whether that bears out in clinical practice needs to be seen.
Yeah. Last question for you, Stefan. COVID is one of the in cardiovascular medicine, one of the key elements in this Congress as well, for good reasons. What are the most interesting news from the field of COVID, cardiovascular, and cardiovascular medicine?
So there was a very interesting presentation from Martin Landry from Oxford University that really made the plea for the necessity of large-scale, simple, randomized clinical trials. And a great example is the recovery trial program that provided important information for the field, where hydroxychloroquine proved not to be useful. However, a very widely available and not costly drug like dexamethasone proved to be important in terms of improving survival. So I think this was one major message.
So thanks, Sonia. Thanks, Stefan, for joining us as experts in the daily wrap-up of day 2 of the ESC digital experience. Stay with us. Tomorrow we will come back to you with another day of exciting science with a focus on prevention and with the latest news from the guidelines. Tomorrow we will have the guidelines on sports and cardiovascular disease. So bye-bye for today.